and welcome to Patient-Centered Treatment for Substance Use Disorder in Primary Care. This is the fourth module in a 12-module series, and this module focuses on OBAT eligibility, intake, and assessment. My name is Claire Nolan, and I am a program manager here at Mi-CCSI, the Michigan Center for Clinical Systems Improvement.
My name is Robin Skur, and I'm an RN Nurse Care Manager, and I'm a trainer for Mi-CCSI.
We do not have any disclosures as presenters of this material. And if you have already participated in a module prior to this, this may be a repeat for you. If you have not, I wanted to provide an overview of the entire program in which you are participating, which is outlined on this slide here. This module is part of a 12-module series. 6 of the modules are clinically focused and 6 of the modules are operationally focused. In the operational modules, our goal is to provide practical guidance on implementation of key components of the OBAT model and beyond. And at the conclusion of each operational module, we'll wrap up with some interviews and testimonials from practices that have implemented materials covered in that particular module. And we'll do that through a brief interview with a number of practices. So for example, at the conclusion of this module, we will have some practices share how they went through the process of implementing processes and procedures for OBAT eligibility screens, intake, and assessment. And a final note is that CE is available for this module for the disciplines listed on the Mi-CCSI website. If you complete this module and the associated pre-test, post-test, and evaluation, you will be granted 1 credit hour if you are eligible. And again, that information can be found on the website. And a reminder that while these modules are numbered, and we really do encourage you to complete all 12 in an order, that is not a requirement. So feel free to pick and choose what best fits your educational needs. A reminder that at the conclusion of Module 2, which was the last operational webinar, we assigned some homework and gave you the opportunity through an action period assignment to work with your team to identify the tool you will use to identify patients across the continuum of substance use disorder. So just a reminder for those of you that have participated in that module, and then maybe a plug for those of you who haven't to go back and review that material. And then you'll have the opportunity to do that with your team as well. So let's move on to the objectives for this presentation. Once we get through this material, you will be able to define the process to screen for participation in the OBAT program, describe what the OBAT intake process looks like, as well as the components of the initial provider assessment. And a quick note here, before we get started on the actual content, that as we're presenting today, we will be referencing specific materials that are available in the toolkit for this module. So we'll be speaking to those materials, but if you feel that it would be helpful for you to visually look at those materials as we talk about them, it now might be a good time to pause this recording and open those toolkit materials. So we will go ahead and now talk about the agenda. We'll review the OBAT module, or the OBAT model. Sorry, I keep confusing my model and module. We'll talk about screening for participation in the model, talk through intake, initial provider assessment, and as I mentioned, then we will do the practice interviews. So this will be a repeat slide for those of you who have participated in previous modules, but are new information for those of you that haven't. I'll go through it briefly. The operational information that you will learn about in these modules comes largely from work out of Boston Medical Center in Massachusetts, where this model was originally developed. What we've done with these particular presentations, these operational focus presentations, is taken the information that Boston Medical Center put out with the OBAT model and supplemented it with additional information and pearls and practical guidance for how to implement this work in practice. or an ultimately patient-centered, evidence-based model that can work in the primary care setting. The model focuses on the use of medication, namely buprenorphine and naloxone, which is available under the trade name Suboxone, in combination with psychosocial support as part of a comprehensive care plan. Patients are screened and identified as eligible for participation in the program. Once enrolled, the goals of the program are to improve, enhance, and restore things like physiologic function, community connection, hope for recovery, and overall quality of life. Additional goals include reducing symptoms and risks associated with substance use disorder, illicit or problematic use, and withdrawal symptoms or cravings. Here are the program components of the entire model of OBAT. Goes from screening all the way to discontinuation of treatment, if that is appropriate for a given patient or by patient choice. And in this module, we will be focusing on screening for participation in the OBAT program, intake into the program, and the initial provider assessment. And with that, I will turn it to Robin.
So we're going to take a look at the OBAT eligibility criteria and initial screening. If you remember in module 2, we talked about how do we even identify out of our own patient population who should even be screened to see if they might have a substance use disorder. Once they've been screened and that's been identified, now we want to move forward and see if they might be eligible for the OBAT model program. So let's take a look at how OBAT identifies candidates. And again, this comes directly from the OBAT manual. So we want to see that there's a DSM-5 diagnosis of substance use disorder. The patient has to be able to attend visits during program hours of operation to be able to come in periodically to the office. If seeking treatment with buprenorphine, no chronic pain requiring full mu-agonist opioid therapy, in other words, such as morphine. Same thing of seeking treatment with naltrexone, not having chronic pain requiring ongoing opioid therapy. So the reason for this is that the medication would diminish the analgesic effect of the mu-agonist. And so the patient would require more opioids to achieve the same pain management, which would not be particularly ideal for someone who is suffering from substance use disorder. So that would really be a barrier for them. And patients should be able to be treated in an office-based setting safely without risk of harm to themselves or people in the practice. So let's think about the OBAT eligibility initial screening. And you'll see here in the little box that it tells the topics that are covered in detail: demographics, social history, housing, the substance use history, including recovery and treatment, and so forth. Just as important to getting the information is how we do it. This should be a patient-centered approach where we are starting the relationship with the patient. And so we want to learn about them. We want to engage them in this process. Once we get this information, this will enable the team to make a decision regarding whether this patient really is a good fit for the program and acceptance into the program. Once that's known, we want timely review so that we can get the patient in quickly. Same day treatment access would be the ideal. And so you will find this OBAT initial screening document in the training and technical assistance manual. So let's talk more about how we would conduct this screening and what it might look like. If you're able to pull up that OBAT screening tool, it's in the current toolkit and it's on page 96 to 104. And you can use this screening tool as is, or you may want to consider modifying it. As you can see, it's very comprehensive. So we wanted to approach this with a conversational style. And so that this is very patient-centered. And so you want to express curiosity and be empathetic. And this would be like a motivational interviewing approach if you're familiar with that, rather than investigational or a real check the box approach. Do you this, do you that, do you this, do you that? And so how to avoid that would be to know your tool, and then thinking about each section, perhaps deciding to start with some kind of open-ended question. One that you can't answer simply yes or no, or just a short answer. So for example, how are things going at home? Might be a good way to start the section on social support. Or where are you currently staying? Might be a great open-ended question for the housing section. And so when you do that, it allows the patient to tell their story. And then if there are pieces of information that you don't yet know, you're not able to fill in, then you can fill in the gaps by asking them those particulars. Consider framing the questions that do not indicate you've determined that they already have substance use, but explore what the patient is experiencing and thinking. You want to understand their awareness and insight and other reasons. Patients may not feel comfortable disclosing a lot about their substance use. So you may want to start in a different section of the screening tool rather than, heading right into this, what are you using and what's your history. You may want to start with demographics and then go to social history to help to establish trust in a working clinical relationship rather than focusing on the substance use to start. Some of these questions are a little sensitive, and so you might want to ask permission ahead of time. For example, in the legal section, you might want to say something like this. Have you had any run-ins with the police in the past, and would you feel comfortable telling me more about that? And that is just being respectful and letting people know that you wish to partner with them and engage in a relationship. Also, in thinking about the OBAT eligibility and initial screening, you want to think about who would do the screening, when would it be done, deciding if you want to use this tool or you want to use parts of it. Is this going to be by telephone or in person? And then how will you document that encounter? So if we put this all together in our minds, this might be a little confusing, thinking Module 2 had to do with patient identification. That is true, and that was simply to see who in our population might have substance use disorder. So we're simply screening for that. Once we have screened for that and patient is identified as positive, then we're thinking about, I wonder if they'd be possible candidates for the OBAT program. And so now the next step then is to do the screening for the OBAT program. And you want to think about the messaging with the patient. If they were positive on their substance use screen and the physician speaks with them and says, yes, we've diagnosed you with substance use disorder, then helping them understand the next step in that, maybe we're going to walk now into doing this initial screening for OBAT eligibility. Think of it like a big funnel where we narrow down further and further and further so that at the end we get the patients who we're going to work with on our caseload. So the OBAT eligibility, once the screening has been accomplished, then the next step would be to have a discussion in our team whether this patient would be a good fit for the program. And so what we marry up here is the initial screening information where we learn about the patient, what their desires and goals might be as well. And then looking at the eligibility features we mentioned before, and then the team making a decision, reviewing all of that and making a decision in a timely way so that the patient can go ahead and access care if they would like to enter into the program. We're going to talk more in future modules about how that team functions and what the team roles and responsibilities would be. Next, we want to set the stage for the OBAT intake. So if the team says that, yes, this patient would be a good fit, and the patient is thinking they might be interested in the program, then we want to think about an actual intake. And as we do this, once again, it's not just the activity itself, but how we do it, that we're building the groundwork for a therapeutic relationship. So next we complete the intake, and you can see that intake form also in the OBAT training manual. Some of this information may be duplicative from the screening. So you're going to want to look at that and decide what you want, not only in your intake screening, or in your initial eligibility screening, but also on the intake form. And then at this time, there will be an opportunity to talk more about the specifics of the program and signing consent forms and getting patient agreement and testing and all of these things, patient education, what they understand about this program, what they should expect, and so forth. And so it's really important at this point to make sure we are accurately assessing the patient's goals for treatment, their strengths for wanting recovery, and risks to the treatment success. At this point too, it's very helpful if the patient will allow it to include the significant other. And this is a way you could approach that. It's been my experience that the significant other may have a different perspective. Would you mind bringing them in? And so that's a nice way to include a friend or family or significant support.
Also, as a component of the intake into the OBAT model within your practice, there are other things you'll want to do as well. For example, laboratory testing and some other pieces of paperwork that we'll discuss in the upcoming slides. In terms of laboratory testing, you want to think about what it is that you will test for as a way to establish a baseline as they proceed throughout treatment. So there are things that you'll want to establish before treatment begins. For example, pregnancy testing when applicable, HIV and hepatitis, syphilis screening, tuberculosis. Depending on which medication you're initiating and what other clinical components are involved in that patient's care, you may also want to obtain complete blood count, CMP, hepatic function levels, hepatitis A serology, and then potentially also screening for chlamydia and gonorrhea. And again, this is a way to establish baseline around the patient's treatment, so continuous monitoring can occur. Also, as a component of the intake process, you'll want to establish a treatment agreement and provide the patient with education on clinic policies. In that agreement, you'll want to provide clarity and set expectations with the patient with a goal of fostering patient engagement. You want to reinforce the messaging that is integral to your patient around, or to your program around, we're here to support you and help you through this process. There are also key pieces of education the patient will need access to. And we'll talk a little bit more about this in the next operational module, but an example I can provide is that when initiating buprenorphine therapy, a patient must be in withdrawal to some extent. So during the intake process, you'll want to make sure that the patient receives information about what that process would look like, and then providing reassurance along the way that this is a journey that you and the patient are on together toward wellness, and talking about what that might look like depending on where they are at baseline. You can also provide connection to resources as a component of that agreement with the patient. And then there are some examples available in the OBAT manual. Some additional components to consider when you're looking at drafting an agreement for your practice, parameters around clinical appointments, and that can include such things as, what's the protocol for when a patient may be missing an appointment, things around random callbacks, counseling, what are policies and procedures around medication refills, what can the patient expect if they do contact your practice with a request for an early refill, toxicology screening, and a behavior agreement. And one point that I do want to emphasize on this slide is that a treatment agreement is not a contract. And Dr. Juni will touch on that in detail in Module 5 on the clinical side. That module is called Challenging Clinical Scenarios in Medications for Opioid Use Disorder, Early Refills in Lost or Stolen Medications. So if you're surprised to hear me say that a treatment agreement and a treatment contract are not the same thing, that would be a good place for you to go next in the journey through learning about this material. And here on this slide, I have an example around what you could place in the clarity and expectation section of your treatment agreement. So on both sides, what the patient can expect and what the OBAT team can expect, dignity and respect is paramount. The patient can expect notification if the office is closed and information on how to seek assistance if needed. They can also expect confidentiality and up-to-date information on how to contact team members involved with their care. The OBAT team, in addition to dignity and respect, can expect notification if the patient is unable to attend an appointment and up-to-date information on how to get into contact with that patient to assist with their treatment needs. And that can be complemented with a conversation with the patient around, we are really here to help you, and if we can't reach you, we can't help you. So this is why this is so important and why we've included it in our treatment agreement. So I think Robin mentioned earlier, setting the stage for that therapeutic relationship, and this is all a part of that process. Also provide patient education to complement information in that agreement. So what do they need to know about the clinic itself? Hours, emergency contact information, and who's on call and when. Warm handoff process to another treatment setting. What will that look like if we get to that point? We need to be providing right in this intake stage information about the medication that the patient will be prescribed with that conversation being or that decision being made in collaboration with the patient. So what is the medication we've ultimately decided on? How does it work? How is it given? What interactions or side effects can we expect? And what will the induction and maintenance process look like, which of course is the focus of our next operational module. Want to be talking to the patient about responsible and safe storage of their medication, and then providing access to resources on harm reduction. And as Robin mentioned as well, this is an excellent opportunity to engage a significant other or support person in the process. Just like with other chronic conditions where it can be helpful to have a second set of ears present, this information can be very overwhelming. And we also want to recognize the fact that at this point in their treatment journey, the patient may still be using the substance they are challenged with using. So they may not be in a state of mind where they're able to take in the amount of information that we're providing. So we want to supplement with written handouts or offer an opportunity for a support person to attend this sort of intake meeting as well. In terms of practical considerations for this step of the process, you want to think about who is going to have this conversation with the patient around intake. Is it going to be one person? Is it going to be multiple patient or multiple members of the care team? Is this an opportunity for the patient to spend a while in the practice and meet every member of the care team that they're going to be interacting with throughout the process? You also want to talk through as a practice, what are you going to include in your treatment agreement? What patient education materials are you going to provide? What are the initial labs that you're going to draw? And what are the next steps for patients who decide not to participate? So just because we as a practice team feel that a patient is eligible for intake into the OBAT program, not every patient is going to be ready for that process. So what do next steps look like for patients that fall into that camp? And then how are you going to document this process? And the OBAT manual itself does provide a framework that you can build from, but you can customize to the needs of your practice, absolutely. Each practice is different, but you can perhaps use that manual as a starting point. So I want to take a step back here and put it all together again, because the initial SUD screen, the OBAT screen, and OBAT intake do have some pieces and parts that have things in common, and there's also some overlap. So just to put it all into context and put it all together, the first step in the process is that initial SUD screen. So that's when you're really determining who in my patient population has a substance use disorder, to what degree do they have a substance use disorder, and what is their risk level resulting from that. Once you have a patient that has been identified as having a substance use disorder, the next step is to screen for eligibility in office-based addiction treatment. And as an integral part of that process of screening, you need to take into consideration the patient's goals and desires, and then make a team decision about whether or not that patient is eligible and would be appropriate for intake into the program, which is the next step of the process. So Robin mentioned that funnel. So you start with your entire population, find out which of those patients have substance use disorder, screen for who is eligible in office-based addiction treatment, and for those patients that are eligible, then they proceed to the intake process. So once they have gone through that intake process, the patient will then have their initial provider assessment. And we will go through the components of that next. So during that initial provider assessment, the provider will collect and/or review the previously completed substance use history, which has taken place previously in the process. They'll assess comorbid conditions, complete a physical exam if needed, collect and/or review lab results, confirm a diagnosis, and assessment of which medication treatment may be appropriate, and then provide patient education. That patient education could include information about medication options and what the initiation process will look like, behavioral health services, peer support meetings and recovery coaching, residential treatment options when appropriate, acute treatment centers, and other complementary treatment modalities such as Reiki, meditation, acupuncture. So all of the pieces that are coming together to support this patient. And then of course, also including information about harm reduction and overdose prevention and response. This is a tool that is available in the OBAT manual, and it is a guide for patients beginning buprenorphine treatment. The patient should be provided with this education early on in the process, prior to the day that they arrive at the clinic for induction. And we'll talk a lot more about this in the next module when we focus specifically on induction and maintenance. But here is an example of a handout that you may want to provide to the patient at this stage of the process. One of the things that we like to say is do it once, do it again, do it at every possible opportunity so that the patient hears the repeated message over and over, and you increase your chance that that message is ingested. And then before we conclude the presentation portion of this module, we want to stress that throughout this entire process, the team is setting the tone for the therapeutic relationship with the patient. You want to, throughout this process, acknowledge the uniqueness of each individual patient, establish patient-driven goals for treatment. So this is a collaborative process with the patient, build rapport, reinforce the view of substance use disorder as a chronic medical condition, and emphasize that support will be continuous, the patient will not be abandoned, and the treatment plan and medication therapy may change over time. And Dr. Juni does a great job in his presentations talking about how vital it is that you expressed interest in what the patient is telling you so that the patient feels empowered to open up to you and share information about their treatment journey with you. So again, like we did in the last module, we'd like to give you the opportunity to take this information back to your practice and engage in an action period. And we would recommend that at this stage in the process, your team work together to identify the tool that you will use to determine patient eligibility for OBAT and define the process your team will follow for intake into the program. So thank you very much for listening to this portion of the presentation. If you have any questions, you can email me at the email address listed there. And now we will hear some examples from practice. And we asked a number of practices the following question. Once a patient has screened positive for substance use disorder, what is the process your team takes for identifying them as appropriate for and engaging them in office-based addiction treatment?
My name is Stacy Hines, and I'm the Director of Integrated Services at Hamilton Community Health Center.
Hi, I'm Mindy Smith. I'm the Executive Director of Behavioral Medicine here at the Family Health Center in Kalamazoo.
I am Rachel Hafner. I work for Sterling Area Health Center, and I'm their nurse care manager for their office-based addiction treatment.
So in your clinic, once you have a patient screened positive for a substance use disorder, so at this point you already know that they have a substance use disorder, what's the process your team takes for identifying whether or not they're appropriate for office-based addiction treatment?
Okay, so one of the first things we do when a patient is identified as having either an opioid use disorder or alcohol use disorder is they actually go through a full biopsychosocial with either our social worker or our LPC. And we collect all the data. It's a 17-page questionnaire that we created in-house so that we can identify what their triggers are, we can identify what their usage patterns are, and then we use that information to determine whether or not this is something we could treat in-house or if they need a different level of care.
Once you have a patient screened positive for a substance use disorder, what's the process your team takes for identifying whether or not they're appropriate for office-based addiction treatment?
So once an individual has been identified as potentially having a substance use disorder and they've been referred to us, there's a couple different steps that we would take, and a lot of that depends on how they were referred to us. Sometimes they're referred to us by a residential center where it's been really confirmed that there's an issue going on and they're appropriate for our level of care. Sometimes the screening will take place at a medical center, and it could be another medical center, it could be internally here. It could be at the emergency department and we receive a referral. Sometimes it could be that the individual self-identifies as having a need for treatment. Either way, once we've received the call or a referral in the computer, what we do is we talk with the individual. We ask them about, are you interested in the service? Tell us a little bit about what's going on. What are you hoping to get? And what we're really looking at is their level of interest in treatment, where they stand in terms of contemplation, pre-contemplation, what are they hoping to gain? And if they really are interested in treatment right now, sometimes people are just really uncomfortable at the moment they've asked for care and they're not interested in kind of long-term, and we hope to work on that stage of change throughout our program. And then obviously, because we are an OBAT, so we use medication in our care, we're looking for lab work, we're looking to make sure that they're physically stable enough for this level of care. Then we also do a very thorough assessment, which involves determining their correct ASAM level of care. And as we're assessing people for our program, one of the things we really have to take into consideration is polysubstance use. So here in West Michigan, as in many other places, methamphetamine is incredibly prevalent. It does not exclude somebody from being in our program, but we do have to consider what is their primary substance of choice. Is it an opioid or alcohol, or is it methamphetamine? And do we think we're going to be able to help that person obtain abstinence from methamphetamine in our level of care, or do we need to look at residential first so that they're going to really be successful here? And the answer is it's not one size fits all. It's going to be different for everyone, and we sit down with the individual and we take a look at their living situation, their level of support, any behavioral health challenges they have, and then we'll develop a plan of care. And it could be residential first, it could be that we refer them to methadone, or it could be that we deem them appropriate for our clinic. We really just want people to be successful, and putting them in the right level of care at the beginning is going to greatly enhance that chance for success, as well as really correctly identifying their stage of change.
So Rachel, once a patient screens positive for substance use disorder, what is the process your team takes to identify them as appropriate for engaging them in the OBAT treatment program in your office?
Once I receive the referral, I obviously read the patient's chart to see what they're being screened for. If they're in office, ideally that would be a warm handoff. I would meet the patient at that time, be able to explain to them more about our program and pretty much get their idea and how they feel about it. If the patient is receptive, then we move forward with that. Provided the time that they have, we go through the nursing assessment. I get all of their information, demographics, history of use. Once I get all that information, we as a team meet on a weekly basis. We meet with a psychiatrist, our therapists, myself, and oftentimes the doctors, who are the primary care physicians, will sit in with us. At that time, I deliver the case, and I receive all the feedback that I need. If I have questions regarding the patient, those questions are answered, as well as getting a determination: is a patient appropriate for our program? Are they in the maintenance phase? Do they need inpatient before we can help them? That's pretty much how the dynamics work. If the patient is appropriate for our program, then I go further into their screening assessment. I get basically much deeper into their life of use and how long it's been, and working with them and their goals, and basically filling out all the rest of the paperwork and starting them on their medications if they're agreeable to it.
How in that process do you evaluate the patient's readiness for care?
So part of our assessment actually includes a readiness to change. So we really have, our social workers are trained in substance use disorders. And so based on how they interview and the responses that they provide, then we're able to gauge where they are on that change process.
You said that you go through the process of determining if it's appropriate for them to be treated in-house. Once you've made that decision, what happens next from your perspective and then also from the patient's perspective?
Okay. So after a patient is determined to be a good fit for in-house treatment, the first thing that happens is then we set up a meet and greet with the provider to kind of talk through what their options are. In our particular clinic, we offer Sublocade, Suboxone, and Vivitrol. And so that conversation is then had between the patient and our provider here to determine which medication would be the best fit for the patient.
Were there any things that you changed over time in your process? Maybe you did it one way to begin with and you've learned things over time and changed, or have you really stuck with what you started with?
So our process has really changed over time. In the beginning, when we started working with patients, I think we were still kind of trying to feel our way, and so we didn't necessarily have a really strict pattern of how people followed. Sometimes they came in and they saw the provider. Sometimes the assessment was after they had their first meet and greet. And what we found is once you get the patient here for the meet and greet, you've set an expectation, right? And this might not be an appropriate level of care. So based on that information, we did change the process, and we always do the screen first. That way we have that information to share with the provider and then to make a decision whether or not they're appropriate for this level of care.
What happens when you determine a patient is not eligible for this level of care? So they maybe need to go to a higher level of care, or?
Absolutely. So when we determine that somebody is not appropriate for this level of care, our social workers, a recovery coach, our counselor will work with the patient to connect them to other community resources. We've actually had them walk patients down to Genesee Health Systems, which is our community mental health, and also does utilization management for inpatient care.
How in that process do you evaluate the patient's readiness for care?
So we begin to identify readiness to change from that first phone call. We're asking questions about who referred you, what are your thoughts on this, what do you hope this looks like. But everyone on our team is responsible. We have an intake coordinator who really begins that conversation, but we have master's level therapists who will do thorough ASAMs. They're having that conversation, and sometimes we'll do medical consultations, and our providers having that conversation. We're completely team-based here. We don't rely on one person to determine that. We also have peer recovery coaches who have those conversations. We really think that by working together, we can best serve these patients and really have honest dialogue with them about how to best meet their needs and how best to help them be successful.
So can you share with me one or more, if you have them, examples from practice of a patient who you had a positive experience with going through this process?
I have several, but I will share with you one of my favorites. This is a man who came in for his primary care appointment and divulged to the doctor that after a back and neck injury, he was prescribed opioids, and he is now having a hard time getting past that. He said, I want my life back. I don't want to be taking medications on a daily basis. Well, we, as far as I know, we're the first people in this area or around us that have started a medication called Sublocade. Sublocade is a once monthly injection for opioid use disorder. And this person opted to take that shot. Well, once I ran his insurance and did all of that, we realized his insurance is going to cover it completely. So out of pocket, he paid for several months over $300. And we're talking about a person, you know, who's limited on their funds, disability and stuff, but was willing to pay for that medication to do what he needed to do to, what he said, get his life back. After several months of that, he's like, I just can't afford it anymore. He's like, it's so hard. So we opted to put him on an oral medication, which he's been going strong with ever since. And I just, when I see him, it makes me so excited because I see the happiness and the regained life that he has gotten.
So can you share with me one or more, if you have them, examples from practice of a patient who you had a positive experience with going through this process?
So we have multiple patients at multiple stages of change, and sometimes they're really in action or maintenance and they're doing well, and sometimes we have them in care and they really are still pre-contemplative. We are patient with that. We will work with them on that. There is one patient who I will share their story with you, and they're not really a success story on its face, but we do consider them a success story. This patient had a pretty significant case. I won't give any particular details, but they had they were diabetic, and it was fairly well managed because their substance use was so significant. And we tried multiple interventions to stabilize both the diabetes and the substance use. We had this individual do residential. We tried multiple types of medication here in our clinic. We tried multiple behavioral health interventions, group, IOP, different levels of individual. And this was over the course of nearly 2 years. And we simply could not stabilize this individual. And we were incredibly concerned about her health. So ultimately we had to discharge her and said, we do not believe that you're safe at this level of care. And just recently we had a conversation. This patient came back and said, thank you for discharging me. Thank you for telling me that it was compromising my safety, what was happening. She is currently completely abstinent of all medications. She is attending 12-step. She's healthier than I've ever seen her, and she's doing wonderfully, and she's in treatment. And that's just sort of the journey for some people. Is she really, nothing we could do right at that time worked for her. She needed to work a different type of program. And I do feel ultimately that was a success, but it was really difficult to watch. It was tough to be part of because we become really invested in our patients, and we care about them. But in the moment we felt like it failed. But ultimately, like, she thanked us, and we do consider her now a success story, and we continue to see her.
Can you please share an example of a time when a patient was engaged in office-based addiction treatment?
We had a patient who began a substance use disorder based on prescription medicine for an injury. So, and we see a lot of that these days, right? It's not just people that have started recreational use. They were getting this medication in a legitimate way with an injury. This individual has been in our program for over a year at this point. They started on Suboxone and have been very stable. This person participates in groups, just really a leader in recovery among their peers, and recently transitioned to Sublocade. And so that long-term management comes into place. And so that's been really kind of the epitome of what we're trying to get to here, right? We really want to see people successfully move through recovery.
And I would like to ask you one final question, which is, in this journey that your practice has gone through, do you see from your team a change in their attitudes around this type of work or their engagement? How are they feeling about doing this work?
I think our team is totally engaged in working with this population. They're very passionate about it. Our social worker and our counselor have both worked with substance use disorders for years, so they came to us with a lot of experience, and they really care about these patients. We have patients that they've known in the community from previous organizations, and those relationships are already existing, and so that just allows us to build on that. Everyone in our program is engaged, from our operations manager to our MA and myself. We're all passionate about making sure people are successful in their recovery.